Okay, a 16-year-old boy is brought to the emergency room after injuring his elbow while skating in the local park. He continues to bleed excessively despite treating and dressing his wound. Blood test results are shown. Partial thromboplastin time is prolonged. Prothrombin time is normal. Bleeding time is normal. Platelet count is normal. Partial thromboplastin time corrects after addition to the acid chamber of plasma from a patient with hemophilia A. Which of the following is the most likely diagnosis? Okay, just by reading the question, this is a bleeding disorder. This question is regarding bleeding disorder. Let's talk about bleeding disorders first, and then we can go over each choice and to see which one is the best fitting. When I think of bleeding disorders, this is just me. I split into two categories. Okay, so bleeding disorders, I split into two categories. Category 1, Category 2. And let's change colors. So category 1, I consider it small bleeds. Small bleeds. Okay. Small bleeds are always caused by platelet deficiency or platelet dysfunction. Platelets. So it's easier for me. Okay. Whereas large bleeds, so the other category will be large bleeds. And I'll tell you what that even means. Large bleeds are primarily caused by clotting factors. Clotting factor defects or deficiency. Okay. All right. So now that we know that, okay. Now let's talk about clotting factors. So what are some examples of clotting factor deficiency? Let's say DIC, which is mixed hemophilia A, right? Hemophilia A, or hemophilia in general. We can think of von Willebrand disease. Okay, similarly, so those are the things. So if it is clotting factor, so then large bleeds are due to clotting factor. That means defect will be in the clotting factor. Okay. So measure of clotting factor defect is called PTT, partial thromboplastin time. So it could be normal or abnormal. PT, at least one of them should be normal because PT represents extrinsic pathway defect. PTT represents intrinsic pathway defect. So clotting factors, okay, so think of it this way. When it comes to clotting factor, the end product of the clotting cascade is fibrin. Fibrin is what makes a clot. So a clot is made of platelets and fibrin. Platelets and fibrin. That's what a clot is made of, which seals a cut in the blood vessels, which to prevent bleeding. So how do you activate thrombin? So remember, prothrombin is converted to thrombin, and then in that sense, we have fibrin. Fibrin is the end product. How do we activate fibrinogen to fibrin? How do we make fibrinogen or convert fibrinogen to its active form, which is fibrin? Well, it can be done by activation through extrinsic pathway or intrinsic pathway. Extrinsic pathway is primarily because of factor 7 and factor 3 in calcium. Intrinsic pathway is primarily factor 8 and 9 in calcium. All of these will eventually activate factor 10 and factor 5, and which activates prothrombin to thrombin, and eventually thrombin can activate fibrinogen to fibrin, and fibrin is what makes a clot. Okay, so that's why we have PT and PTT. Just remember that PTT represents intrinsic pathway, defect in clotting factor 9, 8, and so forth. Whereas extrinsic pathway represents defect in clotting factor 7 or 3. Okay, so if a person has large bleeding, then you should be thinking of clotting factor deficiencies. Okay, large bleeding. What are large bleeding? Examples of large bleeding would be, for example, like tooth extraction, bleeding after tooth extraction. Okay, prolonged menstrual period or menorrhagia. Okay, or epistaxis, which is nosebleed, or when somebody has a wound or a cut and it bleeds, like it's not just a rash, it's actually active bleeding. So that's a large bleed. When you talk about platelets, Platelets usually causes small bleeds, so now the representation of these would be, there's many diseases. Let's talk about like ITP or TTP, or you can think of Glanzmann syndrome. Okay, Glanzmann should be Glanzmann disease, which is platelet defect. Not count is okay, shape is defective. All right. So what are some measurements of platelet defect? Well, we look for platelet count. Platelet count should be usually low if it is count. If count is normal, then it could be due to abnormal shape. But also another thing is bleeding time. Prolonged bleeding time or increased bleeding time is indication of platelet defect. Platelet count usually above 150 to 450 should be normal. Platelet count less than 150 is considered thrombocytopenia or abnormal. It's not clinically significant. Usually clinically significant is less than 100. Less than 50 is an emergency. You have to give them platelet transfusion. But anyhow, so what are some signs of platelet disorders? So it would be petechia, which is small dots, small purple, blue, reddish dots on your skin, which is a rash due to platelet bleeding. It's small bleeding. Purpura is a little bit bigger, and that's also purple, bluish, bruise-like lesion on the skin. And then you have ecchymosis, a little bit larger, which is a patch. Okay, so it's a skin patch in form of rash, ecchymosis. Okay, so look at it. So when we expect small bleeding such that it's caused because of platelet dysfunction, we'll be looking for petechia, purpura, and ecchymosis. But if we expect large bleeding, which is due to clotting factor defect or deficiency, we'll be looking for tooth extraction bleeding after tooth extraction, bleeding after surgery or trauma. It's active bleeding. You can see blood coming out, okay? Or menorrhagia, prolonged menses, compared to platelet, which is primarily a rash. Okay, so hopefully this was helpful, just sort of it guides you. Okay, so when you think of it in this case, it helps us to guide us. But let's go to our question now. What does our question say? The question is telling us it's a 16-year-old boy. So bleeding disorder primarily X-linked. When we see a boy, we should think of X-linked. So any bleeding disorder that's not X-linked, we should rule it out. So that's one. And then it tells us excessive bleeding, right? So let me just highlight those things for us. What are we looking for in this question? It says 16-year-old and it's a boy. So I should have highlighted the boy. Okay, so a boy, and brought to emergency room after injuring his elbow while skating in a local park. He continues to bleed excessively. Excessive bleeding. So that's another sign for us after dressing his wound still. And then his PTT is prolonged. Okay. All the other ones are normal. And then additionally, it tells us that this patient, when hemophilia A plasma is given to this patient, his PTT is corrected. Okay, so PTT is corrected. What is it corrected by? By addition of blood from a hemophilic A type of patient. Okay, so boys X-linked. That's one information. So we got this. The next information is this is excessive bleeding. Excessive bleeding. So we're going to take this information from this question and interpret it to help us diagnose it, right? So excessive bleeding, and then we have PTT is prolonged. PTT is prolonged, so I'll say PTT is increased. Okay, so that's another information. But at the same time, remember that it's telling us PT is normal. PT is normal. Okay, and it's telling us bleeding time is normal. Bleeding time is normal. In addition, it's telling us platelet count is normal. So those information will help us to rule out some diseases. So hemophilia A blood corrects PTT. Okay, there you. That's the four information. If whatever meets this criteria is our diagnosis. Okay, so let's go with these choices. Let's go first. Now, to answer this question, you should know the answer to each one of them. You know, these are high yield information. So I'm choosing these questions for you guys because they're extremely high yield. It covers the main topic or concepts. If you understand the concept properly, then you wouldn't have to keep memorizing things over and over again. Once you understand the concept, you should be able to apply it. DIC. So what is DIC? Disseminated intravascular coagulation. The cause of this is usually diffuse endothelium injury. Endothelium injury, which means endothelium throughout your blood vessels gets injured, such as by maybe sepsis or a toxin that is circulating in blood, which injures many blood vessels, right? So when that happens, what do you think happens? So look, endothelium injury is one of the prerequisites for coagulation or clot formation and complement activation. So you have to think about it. If you have a diffuse endothelium injury, if you have an injury throughout your body of many blood vessels, that means you will consume a lot of platelets. Platelet consumption, a lot of platelets will participate in clotting. So as a result, you would expect platelet count to be low. Okay, so platelet count should be low. This should lead to low platelet count. Okay, so low platelet count. So that's one. And it's going to consume many clotting factors. So intrinsic and extrinsic pathway, all of them. So therefore, PT should be prolonged or increased. PTT should be increased or prolonged. In our questions, we know that only PTT is prolonged, whereas the rest are normal. So this is not our answer anyways, but I'll go over it. Okay. So PTT is increased, PT is increased, platelet count is decreased, and then a lot of clotting factor. I'll put CF for clotting factors. Almost all clotting factors are consumed, so we would expect clotting factor consumption leads to decreased clotting factor. But remember, if there's too much thrombosis, your body wants to maintain hemostasis. Hemostasis is balance between thrombosis and hemolysis. Between thrombosis and bleeding, right? Between clotting and bleeding. So that means some plasmin will be activated, and as a result, you'll have a lot of fibrin split product. Fibrin split product. This is unique to DIC. So you should have that, in which you can also include in here D-dimer. I should have capital D, but anyways, D-dimer. Look for these things. So whenever you see platelets, so look, DIC for me is very easy. All bleeding factors are affected. Everything. Platelet count is affected. PT, PTT, clotting factors, fibrin split product, D-dimers. You will have all of these. No other conditions in terms of bleeding disorder or thrombosis have this. So whenever you have this, you can close your eyes and choose it. So that will be for that. But what do we expect in terms of symptoms? We expect microangiopathic hemolytic anemia. So when I'm writing here MAHA, it stands for microangiopathic hemolytic anemia. So if you have many endothelium damage leads to sharp edges. And as red blood cells are swimming through these areas of sharp edges and corners, it comes and hits them in a burst and leads to hemolysis. And this happens in small vessels. That's why it's called microangiopathic, small blood vessel, hemolytic anemia. Okay? But hemoglobin, myoglobin, and everything else that is released, that can lead to kidney failure. So you will expect acute renal failure as well in this case. And of course, platelet deficiency can lead to petechia. Petechia, which means small bleeding, right? But clotting factors are also consumed. So I will expect like oozing of blood. Okay? Oozing of blood. So you can say blood oozing. So this, in our questions, we don't have any of this except PTT was the only one. So this is not our answer. Let's go to hemophilia A. Hemophilia, remember that DIC is not gender or sex related. It is just injury. It's usually like viral pathogens or maybe toxins in blood that can cause it. Let's go to hemophilia A. Hemophilia A occurs in boys. It's X-linked, okay? So it's X-linked, it is in boys. So that's one criteria so far meeting. And hemophilia A is deficiency of factor 8, clotting factor 8 deficiency. If it's clotting factor, then it's not platelet issues, right? It's not a platelet issue. So clotting factor leads to large bleed. And I'm going to say here large bleed. And you can figure out the rest for yourself. Large bleed. It could be tooth extraction. It can be hemarthrosis. One of the signs of large bleeding I should have mentioned here is hemarthrosis, which means spontaneous bleeding into joints. Hemarthrosis. Hemarthrosis can lead to hemarthritis as well. Okay, so hemarthrosis, look for that. Young boys will have hemarthrosis. Okay, so additionally, so we have clotting factor A deficiency. So clotting factor A deficiency can lead to hemarthrosis and large bleeding. If it's unlikely in females, so you'll be always looking for a boy, right? So look for that. And of course, factor 8 is part of the intrinsic pathway, so you will have prolonged PTT or increase in PTT. Okay, and they should have family history. So let's just say maternal uncle usually. Okay, what happened? So I'll be expecting they may mention in the question maternal uncle is affected. Female are spared. So when I'm thinking of hemophilia A, I'm looking for 4 things. Large bleeding, PTT is increased, maternal uncle affected, and factor A deficiency, or boys. That's it, 4 things. And I will cover you for this exam. Okay, let's go with hemophilia B. Hemophilia B is same thing as hemophilia A. It's X-linked. It occurs in boys. In case of factor 8, it's factor 9 that's deficient. Okay, so it's factor 9 deficiency. It'll have the same thing, large bleeding. It will have PTT increased. It have maternal uncle, everything. The only difference is which factor is deficient between A and B. So A and B are the same thing. You'll be looking for the same information. The only way you can differentiate between them is to see which factor is deficient. Okay, all right. And VWF, von Willebrand disease. Von Willebrand disease is, the cause of it is von Willebrand factor deficiency. Now this is a large molecule, large protein. This protein actually carries factor 8 and prevents factor 8 from clotting. So if you don't have that, factor 8 is active and it's swimming around, it can lead to thrombosis. Okay, so it's not even an issue of so much of bleeding, it's more issue of thrombosis of von Willebrand disease. Okay, so it's autosomal dominant. Autosomal dominant. Look for that, and you should be looking for family history. There is no skip generation. Every generation will have the disease because it's dominant. Okay, and because factor 8 is related to it, so it will lead to factor 8 deficiency. So we expect PTT to be increased as well. Okay, and then factor 8 will be decreased or deficient, because remember, as I said, von Willebrand factor binds factor 8 and stabilizes it. If you don't have a VWF factor, then factor 8 is deficient, and that will lead to bleeding. But it can lead to thrombosis. It's a mixture of two, but primarily bleeding. So we'll look for. And VWF is also required. Remember, VWF is required for platelet adhesion too. If you remember, we did the cardiology or the angiology, maybe angiology 1 and 2, one of those lecture we did or questions we did. In that case, we discussed this in detail, how do you form a thrombus. But if there is VWF deficiency, that means platelet cannot attach to collagen. Okay, so you will have, in this case, you will have both large and small bleed, so that will be unique. Okay, remember, it's not gender related. VWF factors also decrease, so look for these. But in addition to that, symptomatically it'll be small plus large bleed, which means you'll be expecting a bruising like rash plus bleeding. Okay, factor 5 deficiency. Factor 5 deficiency, that's more like if you don't have factor 5, that means it's like anything, it can be both PTT and PTT both are affected. That's large bleeding. PT and PTT both. Factor 7 is primarily extrinsic pathway. So the only way you'll differentiate from the rest of them is, in this case, PT will be increased, whereas PTT is normal. Okay, PTT is normal, platelet count is normal, bleeding time is normal. Look for those things. Okay, so that's factor 7, because factor 7 is part of the extrinsic pathway. Okay, and then we have immune thrombocytopenic purpura. In this case, we have antibody, it's autoimmune disease, remember glycoprotein are uh, found on the surface of platelets, so glycoprotein 2b, 3a will be deficient. If this is deficient, that means platelet cannot aggregate. So there is platelet cannot aggregate, so it's aggregation failure. Platelet aggregation failure. Platelet fails to aggregate. When they're unable to aggregate, these platelet can be wasted, right? So that means it's not going to form a clot, and the result will be small bleeding. Okay, so look for those things. And what are we looking for? Well, because if it's autoimmune, that means this antibody will destroy platelets, so your platelet count will be low. That's the main thing, low platelet count. Look for that always, because it literally, like, these antibody will destroy, especially its IgG. For step 1 purposes, the antibody that attacks platelet is IgG, and IgG coated platelets will be lysed in the spleen, so it can also lead to splenic hemolysis, splenic enlargement. Look for spleen enlargement as well. And the trigger for that is like viral infection, usually occurs in children and female, but it will be like a respiratory infection that leads to increased antibody production, can lead to further trigger of this disease. Okay, so now that we have all of this, that we understand this, let's look at our choices. Okay, we're looking for a disease that is X-linked amongst these. Okay, so the only one so far is hemophilia A and hemophilia B. So these are X-linked. So immediately we can cross out the rest. That's one way of doing it. And then we have excessive bleeding. All of them have excessive bleeding, so that's okay. Whichever disease has PTT increased. We have PTT increased in DIC, but we know that DIC PT is also increased, but we want PT normal, bleeding time normal, platelet count normal. So A is not our choice. Okay, VWF, PTT is increased, but also there is clotting factor 8 deficiency, and it's autosomal dominant, so that's not our choice because we're looking for X-linked, right? So this is autosomal dominant, so we will cross them out. Factor 5, factor 5 deficiency can lead to both PT and PTT increase. Same with factor 7 will be only PT increase, but will be only PT increase, but we're looking for PTT. But remember, in factor 7 deficiency, PT is normal, so that's not our answer. And ITP is the disease of platelet. We're not looking for platelet, we're looking for large bleeding, right? Because this person have excessive large bleeding. And the main thing that differentiates everything is hemophilia A blood corrects PTT. So a patient with hemophilia A are deficient in factor 8. So if you give hemophilia A's patient blood to this person and his bleeding stops, that means this person is not hemophilia A, because he's not deficient in hemophilia A. Why? Because hemophilia A would not have factor 8. So that means this should be hemophilia B, because hemophilia A corrects it. Okay, so that's our answer. Hopefully this was helpful. Okay, so a 15-year-old female is brought to the emergency department by her parents because of 10-day history of progressive shortness of breath. Her menses are regular. Last menstrual period was 7 days ago, and menarche occurred 3 months ago. Her pulse is 90, respiration are 26 per minute, blood pressure is normal, physical examination shows no abnormalities, laboratory study shows carbon dioxide is low, oxygen is normal, and venous oxygen is okay, content is low. Oxygen content. What's the cause? That's what they're asking. So which of the following is the most likely explanation for this finding? So what is the issue? Let's do this. To understand this question, let's do this. So here we have many is the cause is microcytic hypochromic anemia, or is it hyperventilation, or is it hypoventilation, or is it mismatch, ventilation perfusion mismatch, or is it the high altitude? So these are some causes. Well, let's see what is our patient having. So our patient, so I'll put here F is our patient, right? So I mean that shouldn't be a choice. So let's see our patient, and then we can go and explain it. What is our patient experiencing? As our patient has so our patient, in terms of this, our patient's oxygen is normal, which is 96, so that's normal. I'll put N, that is normal. In our patient's carbon dioxide, partial pressure of carbon dioxide is low. 30 is low. Normally should be between 35 and 45. Arterial carbon dioxide. Venous is much higher. Okay. And that's 2. What else do we have? Oxygen content. So let's say oxygen content, and that is content of oxygen. So let's just put C, and I'll put C and then oxygen. Okay. So C, oxygen content. I'll just write it. O2 content. Our patient's oxygen content is very low. Okay. So there you go. These are the lab values, and his respiration is high. Respiratory rate is high. It's about 26. Normal is 12 to 18. And what is his complaint? His chief complaint is shortness of breath, or say dyspnea, which is progressive dyspnea. Okay. So whenever matches this, that'll be our answer, right? So that because this is the patient, whatever causes these symptoms from A to E, that will be our answer. But just to understand, I want to go over something first, and that would, you know what, let's just answer. Okay, so let's go with choice A, or we can go upward. Let's go with E, which is next to my patient. So in E, we expect partial pressure of oxygen to be low. When you go at a higher altitude, the pressure of inspired air is low. So this would be low. In our choice, it is normal, right? Our choice is normal. So for E, it is low. Why can't I do this? For E, it is low. So E cannot be our choice because we want normal oxygen pressure. Let's look at carbon dioxide. When you go at a higher altitude, there's less oxygen in the air higher up. The quantity of oxygen is lower close to the sea level because gravity can pull on it. As you go higher up from the surface of Earth, the quantity or partial pressure of oxygen decreases. Okay. If there's less oxygen and higher up, you're going to increase your respiratory rate so you can inhale and exhale more, right? So you want more oxygen, so your breathing rate will increase. At a higher altitude, you will hyperventilate. Hyperventilation will lead to a decrease in carbon dioxide, and this person is having decrease in carbon dioxide. So, okay, so that kind of matches except the oxygen. Let's go to next is oxygen content. High altitude does not affect content of oxygen. Okay, the content of oxygen, I'll tell you what it is. Let's go over that first so we can understand. Content of oxygen is, so oxygen content should equal to the total amount of oxygen in your blood. So content of oxygen, the total amount of oxygen in your blood. You can call it arterial content and venous content. Okay, so that will make a little bit different because in arterial content will be much higher than venous content of oxygen. But let's look at it. In blood, oxygen can be in the bound form, or it could be in dissolved form. There's 2 forms of oxygen you will find in blood. Bound is to hemoglobin, right? Hemoglobin bound. Bound is 98% of the total oxygen. So majority of the oxygen is carried in the hemoglobin attached form or bound form. only 2% of oxygen in blood is carried in the form of dissolved oxygen. Okay, so if that is the case, bound form will be depending on the quantity of hemoglobin, let's say hemoglobin concentration times oxygen saturation. Okay, how much of that hemoglobin is occupied, and I'll explain what that is. In addition to that, dissolved oxygen is in the form of partial pressure of oxygen. Okay, so you should know this formula will help you a lot. So even if the content is low, dissolve wouldn't affect it so much. 2% is nothing. So I will be focused on the bound form. Okay, let's go over first hemoglobin concentration. What factors could affect hemoglobin concentration? What factors would affect it? Well, anemias. Remember, in thalassemia, is hemoglobin a defect, genetic defect that could affect it? Sickle cell anemia, for example, or you can have hereditary spherocytosis, or even all hemoglobinopathies, right? Or blood loss, because in blood loss, what do? You lose hemorrhage or blood loss, you lose hemoglobin. So whenever we're looking at the content of hemoglobin, content of oxygen in blood, if it's decreased, we will looking for anemia or blood loss. Okay. Next, let's go to this blue, saturation. Saturation meaning that how much of the oxygen is attached to hemoglobin, or how much of the hemoglobin is occupied. Okay, so that's called percent saturation, or oxygen saturation. This will affect on depending if there is a competitor inhibitor for oxygen available, like carbon monoxide. Carbon monoxide would affect oxygen saturation, okay? Or nitric oxide, okay, which is a byproduct of nitrate, so those get affected. Now let's look at the third one. Let's say partial pressure dissolved. Dissolved oxygen in blood would be affected by altitude. Okay, so even if this case the answer is altitude, if there was an answer, I wouldn't choose it because it doesn't really affect, it's only 2%. Okay, but anyhow, let's keep going over this to see what our patient has. Okay. All right, so let's look at it. Maybe I should let me do this for you guys. Let me do this. Imagine, okay, so red hemoglobin is a car. Hemoglobin is a car. Let's look at it that way. Hemoglobin is a car. It has wheels. It travels on the road. Okay, so that's red. Hemoglobin concentration will represent a car or a bus. This bus will have blue is oxygen saturation. So this bus has only 4 seats. 4 seats, which each hemoglobin has 4 subunits. You can consider each of those 4 subunits of a single hemoglobin molecule to be 4 seats. Okay, if all the 4 seats, and let's say oxygen is dissolved oxygen in blood is these individual in purple. Okay, so let's say dissolved oxygen in blood is a person walking by himself. Okay, people walking without a bus. Now, if all 4 seats are empty on the hemoglobin, then the saturation of oxygen on the hemoglobin is 0%. If all seats are occupied, it's 100%. If 3 seats are occupied, it's 75%. If 2 seats, 50%. If 1 seat is occupied, it is 25%. If all seats are occupied, it's 100%. Okay, so this is what it tells you. But if there was somebody, an alien like carbon monoxide, coming in, sitting on the seat, then oxygen cannot occupy that seat. Okay, all right, so let's say here is our person sitting, so these seats are occupied. Okay, when the seats are occupied, that means the hemoglobin is saturated. Okay, so saturation represents occupation of those seats. I hope this makes sense to you. But people who are just walking without a car, without a seat, this would be called dissolved oxygen. Okay, so now let's go to our question. In our questions, remember we had the ventilation perfusion mismatch, we see in altitude. And altitude with oxygen tension in air is low, okay? And as a result, there'll be hyperventilation. The person will be hyperventilating, so carbon dioxide will be low. And the oxygen content is not affected, okay? So the oxygen content is not affected by that. All right, so we will keep that as it is. In addition to the respiration will be increased, that's true, okay? Symptoms could be different, but look, I'm going to tell you something too. The compensation for high altitude should be erythropoiesis. Erythropoiesis, which means now you have to make more red blood cells, more CARs, which will include more hemoglobin, so you can carry more oxygen because you have less oxygen in air. Therefore, the compensation for that should be erythropoiesis. So, which means RBC number will have to be increased, and that's what happens. And the quantity of hemoglobin will increase, so hemoglobin concentration will increase, right? Okay, so as a result, the content could actually increase of oxygen, but because there's less, it will, in that sense, it will stay the same. Okay, so hemoglobin concentration could increase, but the saturation will be less because there is less available. So overall, the content will not change, even though you're increasing the seat in a bus, but the people available are not going to increase too much. So saturation would be low, and that will compensate by it, okay? So content will overall stay the same. You can look at something else. 2, 3, BPG should be increased. So you can exchange this much easier, the oxygen. Let's go over choice of mismatch. Mismatch, okay? In the case of mismatch, so there's two ways perfusion, alveolation, ventilation mismatch can occur. Ventilation means less oxygen coming to blood. So either the alveoli are blocked. If there's a bronchus that is blocked, such as by tumor or something like that, okay, it could be tumor, it could be pulmonary embolus. So ventilation, if ventilation is affected, that means there is a something blocking the bronchus, maybe foreign body, maybe mass, maybe tumor, maybe cancer. So in those cases, there will be less oxygen coming to blood, right? So that's one way. So less oxygen will be coming to blood. So partial pressure of oxygen in blood should be low when it comes to VQ mismatch. Or it could be decreased blood flow, like in case of pulmonary embolism. So an example of VQ mismatch could be either PE or lung cancer, okay, or bronchial obstruction or tracheal obstruction, whatever, one of those airways obstruction, right? So oxygen content, I would expect it to be decreased. This will lead to hyperventilation. So if it's blocked, that means less exchange. Carbon dioxide will increase. Okay. If carbon dioxide increases, pH will decrease. So this leads to respiratory acidosis. We're talking about ventilation perfusion mismatch. But content of oxygen content, I would expect it to be decreased. Yes. Okay. So the content is decreased. Next, the example of this would be pulmonary embolism or bronchial obstruction. Bronchial obstruction. Okay. Let's look at the next choice, which is hypoventilation. In hypoventilation, of course, like when you don't breathe fast enough or you're not breathing properly, so alveolar oxygen is decreased. So oxygen will be decreased, carbon dioxide will increase, and this will lead to respiratory acidosis, or pH will be decreased, okay? But content will not be affected. Content will stay normal. Content, okay? The content, oxygen content is not affected by hyperventilation or hypoventilation, so I'll put it normal for both, okay? And then the main issue for hypoventilation, let's say it's because it's drug-induced, the choice C tells you drug-induced. Opioids are some common causes of this. Opioid can remember cause coma, the 3 C's, pupil constriction, right? Pupil constriction or pinpoint pupil constriction, same thing. And you can have respiratory depression. So respiratory rate will be low. In this person, the respiratory rate is high, right? Hyperventilation, In hyperventilation, you expect oxygen to increase and carbon dioxide to decrease. Okay, content will stay the same, and respiratory rate to increase. Maybe more tachypnic the patient, right? And symptoms of hyperventilation can be dizziness, weakness, syncope, respiratory alkalosis. Look for those things. Let's look at anemia. In anemia, you would expect oxygen pressure to stay the same. Okay, you will expect carbon dioxide pressure to stay the same unless there's tachypnea, right? Okay, so either normal to increase output, normal or increased. Sorry, what did I say? Normal or decreased. That's the carbon dioxide. And respiration. So let's put respiration could increase, could be normal or increased. If it's increased, it will lead to decreased carbon dioxide. But oxygen content will decrease because there's less hemoglobin, right? So oxygen content will be decreased. And the signs, symptoms of anemia should be dyspnea, fatigue, let's say fatigue, and pallor, pale skin. These are the initial signs, right? So look for those. Now let's see which of these choices matches our patient. Our patient, number one, the oxygen tension was normal. So the only one that has oxygen tension normal is, in this case, anemia. So that's a good thing. So that's one thing that's matching. Because look, for hyperventilation, oxygen is increased. For hypoventilation, it's decreased. For mismatch, it's decreased. And for high altitude, it's decreased. Carbon dioxide is low in our patient. The only one that has low is high altitude, but in high altitude, the oxygen was also low. And then, of course, in hyperventilation, but in hyperventilation, oxygen was increased, so it doesn't match much. Okay, so far, what matches is, I shouldn't highlight them all. What matches so far is anemia. Let's do next. Oxygen content. Oxygen content was decreased in anemia, so this matches with our patient. Whereas in hypoventilation, the content is decreased, so this matches too. But remember, in the case of hypoventilation, we would expect carbon dioxide to be increased, so that's not a good thing, so it doesn't match. Okay, respiratory rate is increased. Respiratory rate in our patient is increased, and in anemia, it's increased. The only other case where respiratory rate is increased would be in high altitude. But high altitude, remember, oxygen was low. So just looking at this, the best option would be this. And of course, go back to our formula. Oxygen content equals bound oxygen plus dissolved. Remember, hemoglobin concentration was affected by anemia and by blood loss. Our patient also has blood loss. She has menses, right? She has menses. Let's go here. Her menstrual period was 7 days ago. They're irregular, and her menarche just occurred, so she's just starting to have menses. Usually in the beginning, menses are heavy and prolonged. So the bleeding matches and the anemia matches. So that would be the best choice, A. Okay, so in this question, a 35-year-old female comes to the physician for a routine health maintenance examination. She is heavy smoker and drives long-distance semi-trailer truck for a Walmart. Okay. Her last menstrual period was 2 weeks ago and regular. She is currently taking oral contraceptives. Her medical history is significant for 2 episodes of deep venous thrombosis by pulmonary embolism, complicated by thromboembolism. The physician recommends heparin followed by warfarin therapy. Heparin exerts its effect on thrombolytic balances. Which of the following points in coagulation cascade? Okay, well, they just want to know what is the mechanism of heparin. So as long as you understand the question, that will make life easier. So what are they asking? Mechanism of action, which should be super easy. Mechanism of action of heparin. This is our goal. But they give you in the question stem, there's a female who's 35 years old. She drives a truck, a semi truck for Walmart. She uses oral contraceptive pills. She's a smoker. So all these things, look, long distance driving, smoking, oral contraceptive pills, all these are risk factors for thromboembolism. And she has experienced at least 2 episodes of deep venous thrombosis complicated by pulmonary embolisms. There you go. And at this point, you have no choice but to put her on anticoagulant. In this case, heparin and warfarin, right? Heparin is IV, it's fast acting, whereas warfarin takes about 6 days. So that's why you start with heparin and then followed by warfarin. Warfarin is oral, heparin is IV. Okay, let's go answer this question. So our issue is, what is the mechanism of heparin? You know what? Since we want to do that, let's also give you like a general rule. I want to give you a general understanding of balance between thrombosis and bleeding, okay, which is called hemostasis. So hemostasis, the main thing is, look, what is a clot made of? A clot is made of platelet and fibrin and WBC and everything else. That's, but the main issue, the main component of clot, let's do this, clot, blood clot. The main component of blood clot are fibrin and platelets. Okay, so these are the main components. Now, I want to know, how do we get fibrin? Because that's what coagulation occurs. Okay, so fibrin comes from fibrinogen. Anytime you have gen in terms of proteins or enzyme, these are inactive. So fibrinogen is freely floating in blood. It's inactive. In order for it to become to participate in thrombus formation or clot formation, fibrinogen must be converted to fibrin. And fibrin are hair-like long proteins. It's made of protein, but these are elongated thread-like proteins. Okay, just like when you take shower and there are those hair that clog up your sink, think of fibrin the same thing. Fibrin is like hair is made of protein, fibrin is made of proteins. In terms of structure, they're the same. In terms of function, you can say the same, because blocking sink or blocking blood flow in this case, or bleeding. Okay, so fibrinogen is converted to fibrin. What is it converted by? Well, the main protein that converts fibrinogen to fibrin is called thrombin. Okay, so I'm giving you overall, not all the details. Thrombin. And thrombin comes from prothrombin. Again, prothrombin is an active version of thrombin. Okay, all right. So this is the side where we have a thrombus formation, right, or clot. And I'll say fibrin then participate to make a blood clot. Okay, so prothrombin is converted to thrombin, and then thrombin breaks down fibrinogen or activates fibrinogen into fibrin, and fibrin can participate in blood clot formation. Now, what are some factors that will activate prothrombin to thrombin, or convert prothrombin to thrombin? These are all the other clotting factors, specifically 10 activated. 10A means activated factor, clotting factor 10. Clotting factor 5, these are active form of it. Remember the whole cascade. I don't want to go over the whole cascade, but you can go, for example, there's 2 pathways when it comes to clotting factor activation: extrinsic and intrinsic. Extrinsic starts from clotting factor 7. It's based on clotting factor 7, which can convert prothrombin to thrombin. Intrinsic is primarily based on 8, 9, and 10. So let's say 8, it can convert prothrombin to thrombin. Okay, I'm giving you the main issues here. So this is clot formation. On the other hand, clot breakdown, fibrin breakdown. So you can convert fibrin to fibrin split product. I don't know if you heard of that. So usually, like in DIC, they'll tell you fibrin split product or D-dimers, right? Products, which means you cut a long fibrin like this, you cut into small pieces. That is fibrin split product. Okay, and who does that? Who would do that? It is done by plasmin. plasmin. So plasmin is that breaks down or degrades fibrin into fibrin split product. And plasmin comes from plasminogen. It's an active form is plasminogen. Plasminogen. Okay. Who activates plasminogen into plasmin? That is tissue plasminogen activator, or TPA for short. Streptokinase. There's other version of it as well. Okay. All right. So this is the balance. Remember, there should be balance between plasmin and thrombin. Our main goal is to understand balance between plasmin and thrombin. There's many factors involved in that. So where does, in this case, heparin come from? What is the issue of heparin? Mechanism of action of heparin. Well, heparin, let me change my colors. What should I use? Black. Okay. So heparin activates, okay? Heparin activates anti-thrombin 3. Anti-thrombin 3. So that means heparin is going to inactivate thrombin. That's the main goal of it. Look, it's called antithrombin, right? So heparin potentiates or inactivates antithrombin 3. That's just one of it, but of course it inactivates multiple other factors as well. So the main one is, so heparin is going to inactivate antithrombin 3, and then antithrombin 3 is a large molecule. It binds. So heparin will activate. So I should put activate. I'm going to put plus sign. It activates antithrombin 3. Antithrombin 3 then binds or inactivates. So I'll put negative sign, okay? Then it inactivates factor 10, active factor 10, active factor 2. It blocks these guys from participating in clotting. If you attach to an active form of factor 10 and factor 2, they will no longer will be available. Let me show you a drawing. So imagine this is heparin, large molecule. Heparin is large molecule. Okay, so heparin is this large molecule, right? This is heparin. This dark large molecule is, let's say, heparin, in this case square. And then the active version of thrombin, let's say this is this pink dot, and the active version of factor 10 is this blue dot. As long as blue dot and purple dots are available freely, they're non-attached, they can participate in clotting. But when they're bound by heparin and they're attached by heparin, then they're no longer available for clotting. Okay? They're no longer available for clotting. That's what antithrombin 3 would do. Not only does it inactivate or bind factor 10 and factor 2, but it also bind activated version of 12, 11, 10, 9, 7, 2. I'm giving you two, the major ones, okay? But you can think of it as antithrombin 3 is like it binds many clotting factor. Only it's in the active version, right? The A represents active or activated. So let's go to our questions to see which of these choices will make sense. Well, A tells you antithrombin 3 converts prothrombin to thrombin. No. Who converts prothrombin to thrombin? We said right here, it's 10A and 5A. So A is incorrect. So A is incorrect because it does not activate or deactivate prothrombin to thrombin. But what it does, it inactivates, heparin inactivates 10A. So B, look what B tells you. B blocks 10A from converting prothrombin to thrombin. So that will be the correct answer. That is one of the choices, right? So that's the correct answer. Let's go over C. C is thrombin. Right here, thrombin. Thrombin converts fibrinogen to fibrin, yeah, but heparin has no effect directly on that. Okay, so it doesn't do that. If anything, it blocks it, right? So if there was, so that's one thing. I mean, C, you can go for C as well. That's kind of like, so it would block C as well. It would prevent thrombin from converting. So yeah, I'll go with B and C both. Both are good ones. The only let's go with D. D is 13. It converts fiber into thrombus. No. Plasmin. No. Plasmin will actually break a thrombus, right? Directly. So there's two choices. Both are correct. B and C. Not a good questions, but let's say, I mean, if you get a question like that on exam, you choose B or C, you will get it correct regardless. USMLE will not penalize you for that. Okay. Okay. Okay, so a 13-year-old Caucasian boy is brought to the physician by his parents because of easy fatigability. He has no history of major medical illness. Physical examination shows pallor. Laboratory study shows hemoglobin is 8, which is low. Hematocrit is 24, which is low. Mean corpuscular hemoglobin concentration 34 is normal. Usually I would expect to be high or low, but mean corpuscular volume 90 is normal. A peripheral blood smear is shown. The picture, look at it. Picture. Genetic testing is most likely to show which of the following finding in this patient. Okay, so we're looking for genetic testing. Genetic testing. So what would genetic testing show? Okay, that's our question. But let's see this person's how are we going to diagnose? So number one, it's a 13-year-old Caucasian boy. Whenever boy is mentioned, I think of X-linked unless somebody is distracting you. Young boy, think of X-linked recessive disease. Brought to the physician by his parents because of fatigability. So he gets fatigued easily. Okay, he has no history of major illness. Physical examination shows pallor. So there's some symptoms, and then hemoglobin is low, and corpuscular volume is normal. The rest of the things are normal. Hematocrit is low, which doesn't matter. So these are things. What do we see in the smear? We see these cells look spherical cells. I'm going to color them yellow. These are spherical cells. They don't have the central pallor. Okay, when the central pallor is gone and they're large cells, you think of spherocytosis. So I'm going to say I see spherocytosis. Plus, in addition to that, I also see these blue cells. You can think of this as reticulocytes. Reticulocytes are immature red blood cells that haven't lost most of its organelles. So it indicates hemolysis. Okay, it indicates hemolysis, reticulocytes. Let's see what do we have. So we have 13-year-old boy. That's one thing. In terms of symptoms, we have fatigue and we have pallor or pale skin. Okay. In terms of labs, we have hemoglobin that is 8, which is very low, 8 gram per deciliter. That's very, very low. That's the hemoglobin. Okay, less than 7 or 7 should be requires transfusion of red blood cells, packed red blood cells. And then I think let's look at this too. Mean corpuscular volume is 90, which is normal. Okay, so that's good too. Plus, what do we see in the peripheral smear? We see spherocyte, and we see reticulocytes. You're not going to see a lot of reticulocytes compared to spherocyte. Reticulocytes greater than 1%, indicate hemolytic anemia. Okay, but regardless, when you look at it, this person has anemia. On top of that, you see spherocytes and reticulocytes. I'm going to conclude that this is hereditary spherocytosis. I'm just suspicious, but okay. I don't have evidence for other anemias, but that's what I'm going to think. Okay. Just by knowing that, I should be able to kind of rule out. So if this indicates spherocytosis, which I'm going to write here, let's say my diagnosis is hereditary spherocytosis. Okay. So remember these two, the last two that I'm going to color you, I got it from the picture or peripheral smear. Now, If that is the case, what is the underlying cause of spherocytosis? Spherocytosis is autosomal dominant mutation of ankyrin, spectrin, and band 3, or you can say band 4 sometime. Okay, so one of these protein. Now look, if you get confused with autosomal dominant, autosomal recessive, and these things, always think of it this way. All enzymes are autosomal recessive. All structural proteins are autosomal dominant, or dominant, I should say. Structural proteins are primarily dominant, and enzymes are recessive. Whether it's X-linked or autosomal, you will have to memorize that part. Okay, so this is what it is. Based on this information, I should be able to answer this question, but I'm going to give you further information. So what if you have ankyrin or spectrin or band 3 defective? Defective structural protein leads to spherocyte to be less flexible and they lose the biconcave shape. They're less flexible and they lose the biconcavity. They become more spherical and rigid. So as a result, as they travel through the splenic sinusoids, they get trapped there. Once they get trapped, they can be lysed by splenic macrophages. So this would be splenic hemolysis. Splenic hemolysis. Okay, and you would expect spleen to be enlarged. But anyways, if it's hemolysis, that means red blood cells burst open. They rupture. When they rupture, whatever content they have inside them, they are released. So of course, they're going to release bilirubin. So you will have bilirubinemia as a lab. So look for that. It will be unconjugated bilirubinemia. And bilirubin can lead to gallstones. So complications that will be gallstones. So I'll be looking for gallstones if this question is more detailed. Okay, hemolytic anemia and bilirubin can further lead to jaundice, right? So it gives you jaundice and gallstones. Now, what else can be released from these red blood cells? Well, red blood cells will have hemoglobin. So as these red blood cells burst, they lose hemoglobin. So there will be the hemoglobin concentration should be low. Okay, which we have, and then of course there should be heptoglobin, heptoglobin. Okay, you would expect it to be decreased. Bilirubin will be increased, and the hemoglobin that's released per cell, that too. So what else? LDH is found within red blood cells. Red blood cells don't have mitochondria, so they go through anaerobic respiration or glycolysis. So LDH will be increased when they burst hemolysis. Alkaline phosphatase would be increased. So look for these things if you want to diagnose hemolytic anemia. Okay. So let me tell you, clear-cut signs of hemolytic anemia. Look for jaundice. Oh, sorry. Look for jaundice. Okay. Look for bilirubinemia. Hemoglobin should be low. LDH should be increased. Heptoglobin should be decreased. Reticulocyte count should be increased. Okay, so the reticulocyte count comes from the idea that if a lot of cells are rupturing, to compensate for the loss of red blood cells, your bone marrow will get activated to produce more red blood cells to replace the lost red blood cells. So as a result, reticulocyte count should increase. Okay. All right. So if it is autosomal dominant, that means you need a single copy. You need a single copy of a gene to express the disease. Each generation will have the disease, and you will need a single copy. So you don't need to be homozygous. You'll be looking for something as heterozygous. Okay, so heterozygous, because homozygous will be very difficult for them to carry oxygen. Those red blood cells might not even make it. So there is never any spherocytosis that I have seen that is homozygous dominant. Okay, or homozygous recessive, sorry. Almost all are dominant because maybe the homozygous recessive don't survive. Maybe that's the issue. Okay. Let's look at heterozygous mutation in the alpha globin gene. Alpha globin gene is not spherocytosis, that'll be thalassemia, alpha thalassemia. So I'm not going to choose, I'll cross A. Homozygous mutation in the alpha globulin gene, that will be alpha thalassemia. Beta is beta thalassemia. Beta thalassemia is D as well. E and F are both ankyrin gene mutations, so that's spherocytosis, but we're looking for heterozygous. So our choice should be whatever is heterozygous, which is F. Okay, so hopefully this was good enough to answer this question.